Welcome to the narrated lecture on ultrasound, which is by far the most commonly employed electrophysical modality. Ultrasound uses high-frequency sound waves to affect physiological processes within the body and also via mechanical vibration to cause heating. It therefore has a range of non-thermal effects and thermal effects similar to those previously outlined for other forms of heating. When applying energy to the body, one of the aims is to enhance cell activity as depicted in this graph. There reaches a point, however, when too much energy may be applied and tissue damage occurs, such as burn. This is shown on the far right of the graph. The aim with therapeutic application of energy is to ensure that we apply enough energy to be beneficial but not so much that it becomes detrimental. This therapeutic level of energy is, as you can imagine, difficult to judge, and your observation and assessment of the patient is critical in judging where on this graph you are. Precisely the same issue is present when considering the application of manual techniques to the body. Ultrasound is effectively mechanical vibration applied to the body at high frequencies. These figures demonstrate where therapeutic ultrasound lies in the frequency spectrum. Audible sound is between 20 Hz and 20 kHz, or 20,000 pulses per second. Therapeutic ultrasound is between 0.5 and 5 MHz. Diagnostic ultrasound used in, for example, prenatal care uses much higher frequencies, and the objective here is to measure the reflected energy. Ultrasound is produced within a machine by the application of alternating electrical current to a crystal transducer. The crystal within the treatment head is cut so that it resonates or vibrates at a particular frequency, for example 1 MHz or 3 MHz, which is usually used in the clinical machines for ultrasound. As the crystal vibrates, longitudinal sound waves are set up, with vibrational energy being transferred from the crystal to the metal treatment head and then into the tissues. An additional electrical circuit is used to turn the crystal transducer on and off, producing pulsed ultrasound. The sound energy passes through the tissues in the form of a longitudinal beam of ultrasound wave, and the beam is just slightly less than the diameter of the treatment head. As it passes through the tissues, it is absorbed and scattered and has effects on cells and molecules such that they vibrate, move, rotate, or change shape. These effects are important in producing physiological changes. Energy will also be absorbed by the tissues to produce heat, and the rate of heat formation depends on the frequency of the ultrasound applied and the density of the tissue through which it passes. It is important to recognize that a beam of ultrasound being transmitted through the tissues is irregular, particularly close to the treatment head. This area of ultrasound wave is called the Fresnel zone. Due to absorption and scattering of the wave, it reduces in amplitude with distance. The far field of the ultrasound waves is called the Fraunhofer zone. Energy passes through all of the tissues of the body, each of which has a different density. Ultrasound will pass more quickly through denser materials as the molecules are closer together. In the Fresnel zone, there are peaks and troughs within the sound wave. Those peaks can be 5 to 10 times greater than the set intensity value. The treatment head must therefore be kept moving, usually in small circles or parallel lines. This prevents build-up of excessive energy in any one area. The treatment head is kept at right angles to the skin to ensure that there is adequate skin contact and that the energy is transmitted through the tissues in a more predictable fashion. A coupling medium must be used to transmit the energy from the treatment head into the tissues. This is usually an aqueous gel which transmits almost all of the sound energy into the tissues. The therapeutic effects of ultrasound are attributed to the action of ultrasound waves in the Fresnel zone. Because in the far Fraunhofer zone, the wave has weakened substantially. At boundaries between tissues, the ultrasound wave undergoes changes. This is due to the different abilities of different tissues to transmit the wave, and this is due essentially to their relative density. This is known as their acoustic impedance. Some energy will be reflected back in the direction of the oncoming wave or deflected at an angle. Some energy may also bend as it crosses tissue boundaries. This is reduced between tissues that have similar acoustic impedances. Attenuation describes the loss of energy from the ultrasound beam, and this occurs due to absorption, which accounts for about 60% of attenuation as the wave passes through the tissues. The remainder is reflected or deflected to other tissue areas, where eventually it too will be absorbed. This is of course much less predictable and scattered than the main ultrasound beam, and is not considered important in terms of its physiological effects. An important concept is that of a standing wave, where at tissue boundaries, the reflected wave may combine with the incoming wave. This is particularly a risk at tissue boundaries with bone. Reflection, refraction, and the standing wave are depicted in this diagram. Reflection involves the bouncing back of the wave, whilst refraction is bending of the wave. A standing wave is the combination of the incoming and reflected wave in the area where the two overlap. There is a hugely increased wave intensity which has the potential to cause tissue damage. This table illustrates the amount of reflection and treatment and tissue boundaries. You can see that ultrasound will not be transmitted through air, with all of the sound energy being reflected back into the treatment head. In older ultrasound machines, this is potentially very damaging to the crystal transducer. Modern machines can detect a poor contact and will not emit ultrasound until there is adequate contact with the skin or a conducting medium. The conducting gel transmits 100% of the ultrasound energy with no reflection. The conduction between skin and fat and muscle is very good, with little reflection at all. Conduction between muscle and bone, however, is poor, with just over 1/3 being reflected back. This is therefore a risk area for the setting up of standing waves. Absorption of ultrasound by the tissues is how it will have physiological effects, including heating. Absorption decreases with distance, with a fixed proportion being absorbed at each unit distance. Commonly, the half-value depth is used to describe the depth of penetration. This is where half of the energy applied at the surface remains within the tissues. These figures are useful in determining whether you are likely to be able to target the affected tissue and which treatment frequency head to use. You will see that lower ultrasound frequencies travel deeper into the tissues. Ultrasound, because it may cause heating, is reported to have the following thermal effects. These are similar to the effects of other forms of heat described in an earlier lecture. You will see that there will be preferential heating of tissues with a high acoustic impedance, such as bone and periosteum and the tendon sheath. Any heating produced by ultrasound will be slowly dispersed by a process of conduction through the tissues and by blood flow. Ultrasound also has a range of non-thermal effects caused by the passage of the sound wave through the tissues. These are thought to be most important in terms of producing the claimed physiological effects of this modality. Cavitation describes the formation of small bubbles in fluids that contain gas. This can be shown by applying ultrasound to a container of water, where bubbles will form on the treatment head and in the water itself. These bubbles oscillate and are claimed to produce a range of effects. There are two types of cavitation. Stable cavitation involves low pressures and is beneficial. It has been reported to increase cell membrane permeability and thereby the chance of metabolites to reduce edema, and to stimulate fibroblasts in their role in repairing and laying down new collagen. In chronic conditions, cavitation has been reported to stimulate new cell growth and circulation, to break down adhesion formation, and to increase the tissue elasticity. The second type of cavitation is known as transient cavitation. It involves high pressures and is damaging to the tissues. This may be caused by not moving the treatment head, leading to energy buildup, rapid changes in volume as bubbles form and collapse with the peaks and troughs in the Fresnel zone. This can produce high temperatures and tissue damage. The risk of transient cavitation is reduced by a number of measures, including using pulse ultrasound, reducing the intensity, and applying the ultrasound correctly using a moving treatment head at right angles to the tissues with an appropriate conducting gel. A further non-thermal effect is acoustic streaming. This describes the setting up of local fluid circulation around cells, which has been reported to alter cell membrane permeability and cell activity. Acoustic streaming has been reported to be responsible for increased protein synthesis and other cell activities, thereby aiding the healing process, particularly in the inflammatory and proliferative phase. Micromassage describes the mechanical effect of the sound wave on the tissues and has been reported to help reduce swelling. Ultrasound is predominantly used to treat soft tissue injuries such as muscle and ligament injury. The basic research evidence suggests that it is most effective in the early stages of the healing process and is likely to be less beneficial in later stages. There is some interesting work ongoing to explore the effects of ultrasound on the healing of bone, with some positive findings. This is likely to be an important future focus for researchers in electrotherapy. As is already touched upon, ultrasound is by far the most popular electrophysical modality used by physiotherapists, and there is strong anecdotal evidence for its effectiveness. This anecdotal evidence has to some extent been borne out in the basic laboratory research on cell cultures and animals. The systematic reviews of clinical trials of ultrasound, however, are less supportive, revealing little evidence for the use of ultrasound in conditions such as ankle ligament injuries. These findings should be tempered by the observation that much of the evidence used to make conclusions on the effectiveness of ultrasound in clinical population is of poor quality. This therefore has a knock-on effect on the quality of the conclusions made from systematic reviews of that literature. As is often the case, better quality trials are required before more conclusive statements can be made about ultrasound's effectiveness. The anecdotal evidence, although potentially biased and unreliable, cannot yet be discounted. The application of ultrasound is relatively simple once the therapist is familiar with the particular model they plan to use. A thermal safety test should be performed, as ultrasound may produce thermal effects. The purpose and process of treatment should be clearly explained and the patient's informed consent sought. Ultrasound may be applied using gel, which is most common, or using a water bath. In both cases, it is important to try to reduce the presence of bubbles, as this will reflect the ultrasound. You should move the treatment head continuously during treatment and use an even pressure with the treatment head parallel to the skin surface. Application using a water bath is particularly helpful for irregular or tender areas such as joints of the hand and fingers. You should regularly wipe bubbles off the treatment head. There are many choices to be made regarding the dosage of ultrasound used in treatment. The choice between continuous and pulse ultrasound is generally one of determining whether you want thermal effects or not. Pulse ultrasound will allow time for the dispersal of thermal energy. Lower frequencies for the treatment head will travel deeper in the tissues. The half-depth figures introduced earlier may be a useful guide in determining whether you use, for example, a 1 or 3 MHz head. The intensity of treatment is described in watts per centimeter squared and related to the intensity applied at the skin surface. Low intensity is considered to be roughly 0.2 to 0.3 watts per centimeter squared, and high intensities are anything above 0.8 watts per centimeter squared. Low intensities will obviously be employed for very acute injuries, and the intensities used gradually increasing with chronicity of the condition. The reason being that acute injuries may be easily aggravated, and therefore low ultrasound intensities are used. For chronic conditions, higher ultrasound intensities are used to effect a change in the physiological state of the healing process. Ultrasound is normally applied for 1 minute for every treatment head area. If the area is to be treated is roughly about 5 times larger than the treatment head chosen, then it would therefore be applied for about 5 minutes. Treatment head progression will involve a close assessment of the patient outcomes, particularly pain, swelling, erythema, and heat in the area. These are the 4 cardinal signs of inflammation. Choices are then made to increase treatment time, intensity, pulse rate, or to move from pulsed to continuous treatment. Normally, treatment intensity would be increased in the first instance. There are a very wide range of contraindications for ultrasound, including those listed here. These contraindications will be in your textbooks as well as the EPA manual that you have been provided within this module. Here is a further list of contraindications, and again, these are also provided in the textbooks as well as the EPA manual provided within the module. In summary, ultrasound is applied to the tissues in an attempt to alter physiological processes and to cause thermal effects. It is particularly used for the treatment of soft tissues and is the most commonly used of all electrophysical modalities. Research suggesting beneficial effects in the laboratory indicated that there is a relatively sound scientific rationale for why ultrasound should work to enhance patient outcomes. But this has not been substantiated by strong clinical research evidence. The anecdotal evidence for the effects of ultrasound is high, however, and should not yet be discounted until the clinical research evidence has matured.